You know that feeling when you're really thirsty, right? We all do. But what's interesting is that in a hospital, hydration is so much more than just quenching thirst. It's actually a pretty high-stakes medical intervention. Getting it right is absolutely crucial. And well, getting it wrong can be really, really dangerous.
And to give you an idea of the stakes, get this. One study found that 37% of older patients are already dehydrated the moment they walk through the hospital doors. That's more than 1 in 3 people starting out at a serious disadvantage.
So today, we're going to unpack this whole thing. First, we'll talk about why it's such a delicate balance. Then, we'll get into how different patients have totally different needs. We're going to uncover a hidden culprit called fluid creep, look at some really smart hydration strategies, and then, finally, we'll talk about the way forward.
All right, so let's dive right in with this idea of a delicate balance.
You know, for most of us, drinking a little too much or too little water in a day isn't a huge deal. But for a patient in the hospital, it is a total tightrope walk. If you tip the scales just a little too far one way, you get fluid overload. That can literally fill the lungs with fluid. It's a condition called pulmonary edema, and it can seriously mess up recovery. But tip them the other way into dehydration, and you're risking acute kidney injury or even shock. It's a constant, high-stakes balancing act for clinicians.
And what makes that balancing act even trickier is that there's no magic formula that works for everyone, which brings us right to our next section. Different patients, different needs. It's a real patient puzzle.
And it's pretty wild how much this changes from person to person. Take older adults, for example. As we get older, our sense of thirst can actually get weaker, and our bodies just don't have the same fluid reserves to fall back on. This makes them super vulnerable in a hospital setting. Dehydration in older patients is linked to a much higher risk of big problems like delirium, falls, and infections. And get this, one study found that older patients who are dehydrated when they're admitted are an incredible 6 times more likely to die in the hospital. 6 times!
Okay, now let's flip to a completely different group, surgical patients. In this area, the thinking has really changed. Instead of just hooking everyone up to a one-size-fits-all IV drip, modern approaches use something called Enhanced Recovery Programs, or ERPs. These are super specific, tailored fluid strategies designed to get better outcomes.
And this chart really shows you just how structured it is. An ERP isn't just one thing, it's a whole game plan. You can see here before the operation, the goal is to minimize fasting, maybe even use carbohydrate drinks. Then, during the surgery, the strategy actually splits based on risk. For low-risk patients, the goal is what they call zero balance. Basically, you replace exactly what's lost, no more, no less. But for high-risk patients, it's way more advanced. They use something called goal-directed therapy, with all this dynamic monitoring to fine-tune things like cardiac output. And after surgery, it's all about getting the patient drinking on their own as soon as possible and getting that IV out.
Now, this need for a personalized approach becomes even more important and honestly, more profound at the end of life. Deciding whether to provide clinically assisted hydration is one of the toughest calls for patients, their families, and doctors. The evidence isn't always clear-cut. So the key thing, and this quote says it perfectly, is that decisions need to be individualized and importantly, regularly reviewed to ensure that the objectives of treatment are being achieved. It's all about making sure the treatment aligns with that individual person's goals.
Okay, so we've established it's a balancing act, and it has to be tailored to the patient. But there's another sneaky factor that can throw a huge wrench in the works, a hidden source of fluid that a lot of people don't even consider. This brings us to the problem of fluid creep.
So what in the world is fluid creep? It's such a great term, right? It's all that hidden, unintentional fluid a patient gets, not from the big IV bag for hydration, but from all the liquid that's used to deliver their medications, whether it's through an IV line, a pill they swallow, or a feeding tube.
And this is where it gets really eye-opening. You'd probably guess that most of a patient's fluid comes from those big bags used in an emergency for resuscitation. But check out this chart from a study of ICU patients. Resuscitation fluids, they made up just over 6% of the total. Meanwhile, fluid creep, the liquid just carrying the meds, accounted for almost a third of all fluids given. That is 5 times more fluid coming from just routine medicine delivery than from emergency drips.
So, the big take-home message here is pretty stunning. For a lot of critically ill patients, most of the fluid, sodium, and chloride they get isn't from the dramatic, life-saving stuff. It's from the quiet, routine, day-to-day things like maintenance fluids and just giving them their medicine. It's that slow, steady drip, that creep, that can push them towards fluid overload.
So, recognizing the problem is step 1. But what do we do about it? Let's pivot and talk about some solutions. It's time for smarter hydration strategies.
Now, you might be thinking the answer must be some complicated, expensive new piece of technology. But what's really cool is that some of the most effective strategies are surprisingly simple, pretty low tech, and they focus on changing behavior and processes, especially for those really vulnerable patients.
So let's look at this fantastic case study that focused on older adults. Instead of just one magic bullet, they bundled together a four-step approach. First, a simple flip chart at the bedside to help educate the patient and their family. Second, they created an individualized fluid schedule, a personal game plan for each patient. Third, the staff started doing scheduled hydration rounds, just like they do for medications. And fourth, they used posters and regular staff training to make sure hydration stayed top of mind for everybody.
So, did it actually work? Oh yeah, the results were just dramatic. Look at this. Before they started, only 15% of patients on the geriatric ward were hitting their daily hydration goal. Afterward, that number shot up to 60%. And look at that other bar. The use of physical restraints, which sometimes happens when patients get confused or delirious, dropped by more than half, from 7.5% down to just 3.1%. Better hydration literally led to safer, better care.
And let's not forget our surgical patients. We've already touched on the smart strategies they're using. It's all about sorting by risk. For the high-risk patients, you've got that high-tech, goal-directed therapy, using all the monitors to really dial in the fluid delivery. And for lower-risk patients, it's that careful zero-balance approach, making sure to avoid any extra fluid that could slow down their recovery. Okay, we have covered a ton of ground here, from the basic challenge to patient-specific needs, the secret problem of fluid creep, and some really effective solutions. So let's bring it all together and talk about the guiding principle moving forward.
You know, if there's one single idea to take away from all this, it's this. The best hydration strategy is not a fixed formula. It's not about memorizing a number or a rule. It has to be a dynamic, patient-focused approach that is constantly being checked and rechecked. Because what's right for a patient on Monday might be totally wrong for them by Wednesday.
And making this happen, it's not just one person's job. Preventing dehydration and managing fluids properly is a real team sport. It takes the doctors who make the plan, the nurses on the front lines who are watching the patient every minute, and, this is so important, the caregivers and the patients themselves. Everyone has a role to play.
Which really brings us to our final thought. Knowing this stuff is empowering. Whether it's for you or for someone you love, just understanding how important a personalized hydration plan is can be the first step in advocating for better care. So I'll leave you with this question to chew on. What's one simple question you could ask to help make sure your or your loved one's hydration plan is the right one for them?
All right, let's dive into a critical but often overlooked aspect of hospital care: patient hydration. Here's a shocker. A study found 37% of older patients are already dehydrated when admitted. So why is something so basic so hard to manage in a hospital? Turns out, it's complicated.
And dehydration is way more than just being thirsty. It can cause serious issues, even reflect poor care. And of course, there's no one-size-fits-all solution here. Different patients have totally different needs.
For older adults, for example, their body's thirst alarm just doesn't work as well anymore.
With surgical patients, getting the fluid balance wrong can mean more complications and a longer hospital stay.
Then you have ICU patients who can't drink. For them, that intense thirst is a huge priority. So the choice comes down to giving fluids orally or with an IV, each with its own pros and cons. Take kids, for example. Oral rehydration usually works, but 1 in 25 still ends up needing an IV.
But a huge chunk of a patient's fluid intake is hidden. It's from something called fluid creep.
And this is wild, that fluid creep can account for almost a third of a patient's total daily intake. All that extra, untracked fluid, it can lead to dangerous overloads of sodium and chloride. What this means is, paying attention to these hidden fluids is absolutely crucial for patient safety. So what's the solution? Well, hospitals are getting smarter by tailoring strategies to each patient. For those ICU patients, it turns out a simple spray of cold water was the safest, best fix for thirst. And for surgery, the new approach is a custom fluid plan for before, during, and after the operation. For older adults, they've bundled several simple interventions together to make sure they get enough to drink. And the result? A massive 45% jump in older patients getting the fluids they need. So, in the end, it's clear there's no single magic bullet for hospital hydration.
It really comes down to a team effort, from the doctors and nurses all the way to caregivers.
The goal is to get this balance just right, ensuring this basic need helps, not hinders recovery.